The answer is that even if a patient, friends, is appearing stable, in the paradigm heart failure, it was seen that 20% of so-called stable patients had an event, 17% died during the trial, and you may have a death in 50% even before the patient is hospitalized for heart failure. And out of these deaths, almost half were sudden cardiac death, which is what we want to prevent. Okay, so don't wait till the patient is admitted or the patient deteriorates. Start it upfront as soon as possible. And the 2022, this year, AHA-ACC Heart Failure Association, in patients with reduced EF, class 1A indication, to use ARNI upfront, okay, and reserve the ACE or ARB only if you cannot use ARNI, only if it is not feasible to use. So ARNI upfront. Is acute decompensated heart failure different from de novo? Yes. Okay. Now, in de novo, there is no previous history. Acute decompensation, older people, you already had a previous history of heart failure. In de novo, your comorbidities like COPD, AF, diabetes, stroke, IHT, or previous CABG or PCI is more common. In the first new onset heart failure, you don't see it. The trigger events of acute decompensation, mainly, like I told you earlier, some new infection, failure to take drugs, a new ischemic event, some intervention, or certain drugs. In de novo, it occurs either because of primary cardiac acute coronary syndrome, ischemia, or valve incompetence, or sometimes post-viral, okay. And the presentations are also different. In chronic, it is more of limb edema, ascites, weight gain, orthopnea, whereas in de novo, it is usually more dramatic and severe with pulmonary edema and cardiogenic shock. Okay,